one thing to point out that ERAS, there's a lot of components to it, but what we're talking about is the opioid minimization component. And what we've introduced, and I think all these guys have done this as well at their centers, is we start off with the cocktail before they go to the surgery, like Dan was talking about. That helps.
Drug cocktail.
The drug cocktail, right? Yes, that drug cocktail, right? That's Tylenol, maybe a gabapentinoid, maybe some sort of NSAID in some centers, and potentially acetaminophen or Tylenol. So the other components of it, which is relatively new in spine, is regional blocks, right? So erector spinae blocks. If you get a total knee, right, typically they're giving you some sort of regional block to reduce that pain exposure. So now we're introducing those in spine. Also at our center, when they go to sleep, they get no opioids for the most part. And it used to be the opposite of that, right? So if you talk to the anesthesia folks, when you put somebody to sleep, there's pretty much a hard stop on every single medication, right? Because it becomes toxic at a certain level. There's not a hard stop in opioids. You can put somebody to sleep, and as long as the airway's protected, you can back the truck up and put as many opioids as you want. But that delays their recovery. They don't get up, they don't mobilize quick. So we're reducing opioids when you're asleep. We're using regional blocks to help, right? And then the other thing is we've standardized the way we treat the pain afterwards in the hospital, right? When we first looked at our data, between 8 partners, the variability was massive, right? So now we standardize that and we escalate it appropriately. So there's a lot of components within ERAS, then there's a lot of components just within the opioid minimization component of it. And all these guys are helping lead the way on how to fight that component.